You mentioned that you didn't have the best grades, and
I had good grades. I wasn't the best test taker.
You didn't have the
My
best.
standardized test scores were average, probably at best.
So you weren't the best at that.
Right.
Yet, because of drive and interest, which showed in interviews and so forth, you were able to get to the position that you're in.
Yep.
I think when people look at doctors, especially ones that are in high positions, they view them as these sort of like people who have always been on the nose, always been bookish, because of course the amount of study is extremely intensive and it's regulated by tests. I mean, not necessarily standardized tests, but medical tests, because you can't have someone who doesn't know everything,
Right.
in this position.
Exactly.
The certification degree is of a very high degree. But anyway, you're a human, and all the doctors are humans, and they're probably more like you, who were not the best at standardized tests, or maybe they weren't the best at memorization, but other aspects of them ended up filling in the hole. And maybe those aspects that they weren't good at ended up getting better. So could you comment on that personally? What was that
So
like?
yeah, it's very interesting. Like when I first started residency, my first 2 rotations were with the 2 busiest doctors in the practice, and you had to learn quickly how to navigate and manage a large patient load and get notes done on time and all the documents and tests in order. So basically I got thrown right in the deep end, and it was like sink or swim. And fortunately the clinic was very well run, and I was able to grow and catch on how to be efficient in the clinic. That right now is one of my very big strengths.
What?
Being able to see a patient, evaluate the patient, get them in quickly, get them started quickly, and without a lot of delay. Now, sometimes the delays are from insurance, and our hands are tied by that. But even with me, I have one of the most busiest schedules in our group. Yet I think we've got the clinic working in such a way, and I'm able to still accommodate when the head of the cancer center says, "Hey, I got this patient here. Can you get him into the clinic? He needs to get started soon." It's like, all right, send him down. Barring any insurance issues, send him down. I'll get him in. We'll get him worked up. Don't worry about it. I think that's one of the strengths that has really grown in me. Now, even when I was at Moffitt and I only had 2.5 days of clinic, I was never really drowning. Things got done. I learned to get things done quickly, just so that I could get back to going doing my research thing. But I never turned down a referral. I never turned down an add-on patient, even if it was near the end of the day. You build your reputation and your practice's reputation on keeping the referring docs happy. And at the same time, not just getting their patients in, but making sure they're getting high quality care as well, and in an efficient manner. And there's a lot of coordination that has to go on with oncology, coordinating start with chemotherapy, with radiation, doing it, making sure that, if it's done in a preoperative manner, to make sure that you call the surgeon and get them in so that they can be evaluated preoperatively. You don't want to wait too long. There can be potential complications. So communicating with referring docs is one of the big key things, I think, to keeping a successful practice, especially in this age of multidisciplinary care, where they're getting everything, right? They're getting chemotherapy, radiation, and surgery, and they all have to be integrated and managed efficiently.
Who makes these decisions then?
So
it
depends. Yeah, it depends on what treatment is being delivered at what time. So let's say someone is starting with chemotherapy, then the medical oncologist is going to control that. But then let's say they're coming for radiation therapy, then I have more of say in what's going on, because I'll know when the patient's going to finish their treatment as I'm evaluating them weekly. And then so once I know they're getting near the end of treatment, boom, I'm making the calls to the surgeons, and not just saying, okay, telling my scheduler, hey, he needs to see so-and-so. I'm calling the docs themselves, shooting them an email, as well as their PAs. And so that's also the key. If you know their PAs, get to know their PAs, because their PAs will get them in a timely manner as well. Even double booking, because the schedulers are limited, they're not allowed to double book or triple book, but the doctors can say, yeah, just allow that. So that's one of the keys is communication, being efficient in the clinic, but not efficient in the clinic where you're spending 5 minutes with each patient, but knowing what you're going to do and what you're going to say before you even see the patient. So one of the big things is doing clinic prep, looking at everything that's been done, reviewing all the images, reviewing the pathology reports, looking at everything, and then making sure that this is that this patient fits what you're going to recommend. So the minute I walk in, I do my history, verify everything, and then I already know what I'm going to do. I already know what I'm going to do before I see the patient. Sometimes I'm doing clinic prep 1 or 2 days in advance, because sometimes I know I need off, sometimes I know I need some things.
Is it fun sitting there planning it?
It's not fun. It's very tedious at times, and it keeps you sitting rather than moving. But this is necessary to be able to run an efficient clinic, especially if you want to manage a large patient volume and coordinate all this multidisciplinary care. It does take hours. So sometimes I'm coming in at like 6 or 7 o'clock in the morning, reviewing all the patients' stuff, so that when I know they're coming in, I know what we're going to do. Sometimes the visits are quick. It's like, hey, your scans are great. You're not having any side effects. Let's see you in 3 months. They're like, yay. They're happy about it. Other times you got to spend an hour. It's like, okay, yeah, so you have a recurrence. This is what we should do. So that's one thing, that efficiency doesn't necessarily mean just go in and get out, but going in knowing what you're going to do, not trying to figure out what you're going to do, and that helps to get patients going much more efficiently.